Single anastomosis duodeno-ileostomy with sleeve gastrectomy Sadis. Patient with obesity grade 6. General data. A 31 years old male patient. Diagnostic. Obesity grade 6. BMI 73.5. Personal background. High blood pressure. Fatty liver. Insulin resistance. Dyslipidemia. Obstructive sleep apnea syndrome. The sleeve gastrectomy is performed until the angle of his is identified, allowing for the identification of the gastroesophageal junction and the left pillar at the esophageal hiatus. Distally, dissection of the pylorus continues. The round ligament of the liver is sectioned. Dissection of the first portion of the duodenum is performed, both on its anterior and posterior surfaces, 3 cm posterior to the pylorus. It is important to identify the gastroduodenal artery and branches of the superior pancreatic duodenal arteries. The stomach is calibrated with a 38 French dilator. Gastric section is performed with a stapler using 5 purple cartridges of 60 cm. The duodenum is sectioned in its first portion with a 60 cm cartridge. The cecum, ileocecal valve, and terminal ileum are located, from which 300 cm are counted proximally, which will be the total size of the common intestinal loop. The common loop of the biliopancreatic loop is identified with clips in the mesentery. The duodeno-ileostomy is performed with a 45 cm beige cartridge and a continuous invaginating suture of proline. A methylene blue test is performed, which is negative for leaks from the anastomosis. Intraoperative endoscopy is conducted, observing adequate passage at the pylorus with the anastomosis in good condition and no leaks, and both loops of intestine are of adequate size. Patient with adequate evolution. Medical discharge 48 hours after hospital stay. Follow-up by a multidisciplinary team. Optimal clinical response and improvement of obesity complications after 6th month. The Sadis procedure is an excellent and safe technique that can be an alternative for the management of patients with high BMI values for the resolution of their comorbidities, in whom gastric bypass is contraindicated, and it shows comparable results to conventional techniques.